Good evening and welcome to our practitioner webinar this evening. My name is Catherine Norton and I am the CEO and Director of Heal with Laser. And it gives me a lot of pleasure to bring to you tonight's event, very special event with our researcher from Belgium, Dr. Jolien Rabains. So while we're waiting for people to come on board, I'm going to go ahead and share my screen and get started with some background information for us. Let me just get to the display. There we go. All right. So let me just say tonight's topic is photobiomodulation therapy, or PBMT, in supportive cancer care. And it's the first of two webinars that we have scheduled for you. Now, while we're waiting for people to come on, let me just tell you a little bit about Heal with Laser. We are based in Brisbane, Australia. We partner with practitioners to provide innovative laser technology to enhance clinical treatments and clinical outcomes. Our mission is to help you get patients better faster and in a safe way. Laser offers a pain-free, drug-free alternative to treatment. It provides a non-invasive therapeutic solution. A lot of times I get asked, does it work? So tonight we have an international researcher that's going to show us that laser does work. She's going to explain to us how it works, and we're going to review some of the results that she has achieved with laser therapy. It's very important, I think, that we all understand the research and take some time to really think about it for a number of reasons. First of all, it certainly enhances our knowledge and our own education, which goes to help build our credibility, especially when we're talking with other practitioners and clinicians. And very importantly, it helps us tell a compelling story to our patients. We can explain to patients what's happening, what laser is about, what they can expect from any of their treatments. So that's why it's very important. Let me just say we have another follow-up webinar coming on the 2nd of September. The second in this series that's going to be looking at PBMT and lymphedema. So certainly hope you will join us for that one as well. Also, we have got some further information available for you via our website, and you have the link there in front of you, or if you have your camera, you can download this QR code right now, and that'll take you to a page with some further information. So let's look at tonight's webinar. We are going to have a presentation about 40 minutes. We'll have questions at the end, so put those in the chat box and we will get to them. And so now I would like to say welcome to our presenter, Dr. Jolien Rabains. Jolien has a background in biomedical science from Hasselt University in Belgium. Now, Jolien has got a master's and a PhD in this area. And as a researcher myself, I know the dedication and commitment it takes to follow a career in research. And what that means for Jolien in her quest is to focus on the use of PBMT in supportive cancer care. And that translates to conducting more research, looking at ways laser can be implemented, and also sharing her knowledge, which is the purpose of tonight's event. Jolien has also been part of a group that has established Lowlight, which is a consortium of hospitals and research institutes in Belgium. So I certainly encourage you to take a look at that website and find out more information about what they're doing. Some of Jolien's research includes breast cancer patients in lasers and medical science. She's also published in the Belgian Journal of Medical Oncology and has looked at radiodermatitis, which she's speaking about tonight. In addition, Jolien is a member of a number of different associations. She's presented conference papers all over the world, and we're very, very happy to have her here tonight. So I say welcome. Het is een genoegen om je hier te hebben. And that is a very Australian way of saying welcome and happy to have you on board. So thank you very much for tonight.
Thank you very much, Catherine and Annabelle, for giving me the opportunity to present our research of Lowlight at this very interesting webinar. And I'm really pleased that there are so many participants today to join me for this webinar on acute radiodermatitis. So let's start off with my presentation. If there are any questions, please be free to ask them in the chat, or afterwards I will answer them. So I would like to introduce my presentation by a quote of a Swiss natural healer called Arnold Rickley. And one of his quotes was, "Water will do the job, but the impact of air is superior and that of light is supreme." And that I want to show you today that especially light is important and can be very beneficial for the human health. And also in supportive cancer care, light can be a solution to many problems. So today I will talk about the use of photobiomodulation in supportive cancer care, and especially in the field of acute radiodermatitis. So as Catherine already told you, I'm a postdoctoral researcher at Hasselt University, and I work in close collaboration with two main hospitals in the province of Limburg, which are the Jesse Hospital and Ziekenhuis Oost-Limburg. And like Catherine already told, we started up in November 2019 our own institute called LOLIGHT, or the Limburg Oncologic Laser Institute, in which we investigate the use of PBM in supportive cancer care, but we also use it as a treatment for cancer patients. And like we are doing today, we are sharing our research with other people in the field. So let's start off with the presentation. And first things first, I will explain you very shortly what is acute radiodermatitis and how does it develop. So acute radiodermatitis is a side effect of radiotherapy. Radiotherapy is a type of cancer therapy that uses ionizing radiation to damage the cancer cells, the DNA of the cancer cells, in order to destroy the tumor. And based on figures that we have from 2020, about 90 million people were diagnosed with cancer worldwide, and around 50% of these patients need to undergo radiotherapy as part of their cancer treatment. Now, for our research, we mainly focus on two types of cancer patients, and that are breast cancer patients and also head and neck cancer patients. So the focus on these type of patients today, but it doesn't mean that you can't use PBM in other types of cancer patients. As we already know, cancer therapy is especially used to damage the cancer cells, the cells that are affecting, making the body sick. But of course, by using cancer therapy like chemotherapy, radiotherapy, it also damages the healthy surrounding cells. And there are a lot of side effects, specifically due to radiotherapy, are radiodermatitis, which I will talk about today, but also other side effects like oral mucositis, dysgeusia, diarrhea, fatigue, that all can develop during a radiotherapy treatment. And by doing supportive cancer care, we really try to reduce those side effects and help patients, and also improve the patient's quality of life during and after their cancer treatment. But we still see today that around 90 to 95% of the patients develop some degree of radiodermatitis. Now, we see that there are two types of radiodermatitis. You have an acute type, which I will focus on today. Acute radiodermatitis, like you can see here on a clinical picture, is characterized by erythema. In some cases, dry or moist desquamation can arise, sometimes in combination with edema. Acute radiodermatitis is called acute because it can already develop the first few hours to first week or second week after the first radiotherapy session. Normally, acute radiodermatitis resolves 2 to 3 weeks after the final radiotherapy session. On the other hand, we have chronic radiodermatitis. Chronic radiodermatitis is more characterized by fibrosis, atrophy of the skin, and discoloration. And this type of radiodermatitis still can develop months to years after the radiotherapy. Now, the focus of our research is more on acute radiodermatitis, but there are some research groups in the world, especially in New York. There is a research project under Professor Ken Yu, who is investigating the use of PBM for chronic radiodermatitis in head and neck cancer patients. So that's very exciting to have some of these results in the next few years, I hope so. But today we will focus specifically on the acute type. Now, how does acute radiodermatitis especially develop? So I already told you that we will use the ionizing radiation to specifically damage the cancer cells, so the DNA of the cancer cells. But of course, we need to pass through the skin, so we also will damage the surrounding healthy skin cells. And in a normal situation, the skin will have some repair mechanism. So they are in the basal layer of the skin, you have epidermal stem cells. And those stem cells will replace the skin about each 2 weeks. So they will produce new cells and they will move from downwards, upwards to the epidermis, and then the old dead cells, they will shed off. And that is a normal process that will take about 2 weeks. And this process will still go on during radiotherapy. However, like I already told you, radiotherapy will lead to some damage also of the skin. So in first instance, there will be an inflammatory skin reaction. And so the skin becomes more red. There is a vasodilatation of the blood vessels in the dermis. And there's a first skin reaction that we see in these type of patients. But how more radiotherapy is given, you can see that more and more skin cells will also become damaged by the radiotherapy, and also the DNA of those skin cells will be damaged. So in first instance, the skin will react to the damage by replacing the dead cells, the damaged cells. But at a certain instance, the damage becomes too large and there will no repopulation of stem cells anymore. And that can eventually lead to, there will be shedding of dead cells at the epidermis, but there will be no replacement of new cells from the basal layer because they all will be damaged by the radiotherapy. So at a certain moment, there will be shedding of cells. And eventually, when there will no replacement of those cells, moist desquamation can arise in that case. So there are different grades of acute radiodermatitis, and they can be graded based on the radiation therapy oncology group criteria. And here I will show you the modified version of these criteria. So a grade 1 skin reaction is a skin reaction that we see in most patients. So up to 95% of the patients, mostly 100% of the patients, will develop some degree of radiodermatitis, and especially grade 1. A grade 1 skin reaction is characterized by erythema, and sometimes also dry desquamation can arise. Then a grade 2A skin reaction is characterized by a more bright erythema, like you can see here on the clinical picture. And a grade 2B skin reaction is characterized by moist desquamation, like I explained to you in the previous slide. A moist desquamation, but a grade 2B is really characterized by only moist desquamation by in the skin folds. So here for this patient, for example, in the axilla or in the inframammary fold. And then a grade 3 skin reaction is depicted by the confluent moist desquamation. So when the whole treatment area, irradiated area is affected, and it's not only confined to the skin folds. Now, when we are looking to the radiotherapy patients today, and at our institute in Belgium, we see confluent moist desquamation only in very few patients due to the improvements of the radiotherapy techniques, due to the improvement in the standard skincare protocol. We see it not that often anymore, thankfully. Now, what are the risk factors for development of acute radiodermatitis? And there are a few. There are patient and there are therapy-related risk factors. There are the treatment-related risk factors are, of course, related to the radiotherapy scheme and the techniques that are used. So it is dependent on the radiotherapy regime, how many fractions are given, what is the total dose that is given to the patient, what type of area is treated, is it breast or head and neck, or the gynecological area. That already all depends on the treatment schedule. And on the other hand, we also have some patient-related risk factors that can enhance the development of acute radiodermatitis, such as age. Older patients are more prone to develop more severe skin reactions. Patients' BMI, and also it's correlated to that the presence of skin folds. So patients with a higher BMI have probably also more skin folds, and those regions are very sensitive to the development of radiodermatitis, and especially moist desquamation, because there is more rubbing of the skin in these areas, more shear stress, so that will also lead to an increased risk on acute radiodermatitis. Also, patients who are smoking have an increased risk on this type of skin reaction, and also the presence of pre-existing skin conditions like eczema, psoriasis, but also some genetic sensitivity can also enhance the risk. So they are very, on one hand, very therapy dependent, but on the other hand, you really need to have one patient can react very well to one radiotherapy scheme, while the other can have a very extreme reaction. So it's really patient dependent also. Now, the standard advice for radiodermatitis, but it's really also institute dependent. So it can be that for your institute, it can be a little bit different, because there still today, there is no really standard protocol. How can we prevent and manage acute radiodermatitis? The Multinational Association for Supportive Cancer Care has published a guideline in 2013. It was written by Wang and co-authors. They did give some suggestions and recommendations how to prevent and manage acute radiodermatitis, but there is no golden standard. They are now writing a new protocol, so I hope it will be published next year on this type of condition. But there are so many different researchers and different outcomes of research, so it's still very difficult to have one gold standard to prevent and manage radiodermatitis. But also we in Belgium also have a working group that is focusing on radiodermatitis, and we based our guidelines on the MAS guidelines and on our own clinical experience. So the standard advice for acute radiodermatitis based on the guidelines of the VVRO and the MASC are using gentle washing the irradiated area with water, with or without a mild soap. patients are prohibited to sunbathe and to go into the sauna or into the swimming pool because they can dry out the skin, of course, a little bit more. They are not allowed to use any wound plaster in the irradiated area because it can tear up the skin more. They are also advised to wear more loose fit clothing and pat the skin dry, so do not rub the skin. And they are also not allowed to use any perfume or aftershave in the irradiated area. And they are also advised to use a deodorant without an alcohol. So that's the standard advice that we give to our patients at the Radiotherapy Institute. And next to that, we also advise our patients to use a hydrating cream 2 to 3 times a day from the start of the radiotherapy. And still use it until they develop a grade 1 skin reaction. When they develop a more bright erythema or a more painful skin reaction, we can also give the patients a wound dressing to apply it on the more painful areas of the skin, and that will give a more soothing effect. And also these wound dressings can also be applied on moist wounds. So when the skin is open, we can also use this type of skin dressings, but we can also use a more specific wound dressing in case of a more confluent moist desquamation, and then we use it in combination with a hydrocolloid gel. So this is what we use in a standard setting for our patients. But next to that, we were still looking for extra additional solutions to reduce the impact of radiodermatitis and make it more bearable for the patient during and after the radiotherapy. But it can still be a painful and sometimes also very itching type of skin reaction. So we really wanted to see, can we use PBM for acute radiodermatitis, because we had a very good results using PBM for oral mucositis. Oral mucositis is also a known side effect of chemotherapy and radiotherapy. And the pathogenesis of oral mucositis and radiodermatitis resemble. So we looked into literature, and now we set up also our own clinical trials on PBM and acute radiodermatitis. So, but first, before I go into our own studies, I will explain you a little bit more about what is PBM and how does it work. So PBM is the abbreviation for photobiomodulation therapy, and it uses non-ionizing optical radiation in the visible and or near-infrared spectral range. And it can be produced by laser diodes or by light emitting diodes, because we see nowadays a little bit more the light emitting diodes on the market, but we still, in our research group, we still are using the laser diodes. So the M6 MLS laser is our main device that we are using at our institute. And what we want to do is use this optical radiation to induce photophysical and photochemical events at various biological scales without eliciting dermal damage, which is very important. We are not causing damage. We are really stimulating the damage repair in this case. So there's a question we get a lot from patients. Does it hurt to get PBM treatment? No, it does not hurt. You don't feel it at all. You only need to wear special glasses during the therapy to prevent eye damage, of course. Now, the mechanism itself, so when we apply PBM to the target tissue, the light is absorbed by the mitochondria, so the energy central stations of the cells, and that will lead to an absorption. So the light will be absorbed by cytochrome C oxidase. Like you can see here, cytochrome C oxidase is the main chromophore of the mitochondria, and that will lead to 3 main mechanisms. First of all, it will lead to an upregulation of ATP. So the ATP is the main energy molecule of the cell, so it will upregulate the production of energy. So it will increase the performance of the cell and give the cells more energy to repair the damage. Next to that, there will be also an increase in nitric oxide. Nitric oxide has two main mechanisms or activities. First of all, it can act as a vasodilator, so it will increase the blood flow to the target tissue that is treated by PBM. And next to that, NO can also act as a sort of secondary messenger molecule that will lead to activation of downstream pathways that will also enhance the repair mechanism of the cells. And finally, it will also upregulate the production of ROS, so reactive oxygen species. Now, I often get the question, isn't ROS bad for cells? Yes, in high concentrations, ROS is bad, so it can lead to damage. But by using PBM, we will lead to a slow and a very slight increase of ROS. So a low ROS concentration has a good effect on the cell. So it can act as, in this case, it can act as a signaling molecule, and it will lead to activation of transcription of cellular processes in this nucleus of the cell, which will also lead to production of repair mechanisms and downregulation of inflammatory processes in the cell. So in general, PBM has three main mechanisms. First of all, it has a wound healing effect, so it will lead to more regenerative mechanism by stimulating different cellular processes. Next to that, by stimulating ATP production, it also increases the cell's energy and lead to more energy and more performance for the cell to repair the damage. It also has an analgesic effect, so it can also downregulate pain. And it also has an anti-inflammatory effect. So that are the main mechanisms of PBM in the cell. And these three main mechanisms have been demonstrated in several fields. So not only in the wound healing, but also in neurology, physiotherapy, dermatology, dentistry. So it's not specifically in the wound healing story that I'm telling you today. Now, today, of course, I will focus a little bit more on that wound healing path. And when we are looking at wound healing is divided in 4 different phases. There's a bleeding phase, an inflammatory phase, a proliferative phase, and a remodeling phase. And PBM has an effect in all these 4 phases. So in the bleeding phase, PBM can promote platelet aggregation and activation. But also in inflammatory phase, PBM can downregulate inflammatory mediators and enhance phagocytosis and promote proliferation and degranulation of mast cells. But also in the proliferative phase, PBM has a beneficial effect by inducing cell proliferation of keratinocytes and fibroblasts. It enhances the deposition of extracellular matrix, and it can also stimulate angiogenesis. And finally, also in the remodeling phase, PBM can have a positive effect by increasing the production of collagen and granulation tissue. It can improve tensile strength and lead to a faster epithelialization. So these are results that have been shown in vitro and in vivo studies in the past. Now, this is also more an overview slide, also to show you the difference between PBM, which was also called in the past the low-level laser therapy or light therapy. So it is called this way because it really stimulates the healing of the tissue without causing any damage. And you can also see what more ablative lasers, fractional lasers can do to the wound healing. But especially PBM has a main effect in this acute phase of wound healing. So it reduces pain and stimulates the cell migration and proliferation and the production and remodeling of the extracellular matrix. And it also enhances the vascular blood supply, which also is very beneficial to the wound healing process in general. So that's a little bit more how PBM influences the wound healing in general. And what we know from our research and what we saw is that PBM, of course, also has a very beneficial effect on acute radiodermatitis. And based on the research we did, we saw that by using PBM, I explained to you in a previous slide that radiotherapy limits the repopulation of the skin cells from the basal layer. But what we know from our research and from previous research is that by applying PBM, we can stimulate those basal epidermal stem cells by doing the repopulation. And by that, we can prevent that the development of moist desquamation, because we can, by applying PBM, we can stimulate repopulation of the basal stem cells, which was prevented by the application of radiotherapy. So by this, we hope to see that there are no development of any moist wounds anymore in this case. So it's a mechanism that we have in mind, how PBM can prevent the development of especially moist wounds. So that is what we saw in literature, what was already available from in vitro and in vivo studies. But our main topic or our main field is doing more clinical research. And when we started doing the studies in PBM, so our first study was in 2013 on acute radiodermatitis, we first looked into literature, what is already known about PBM and acute radiodermatitis. And we wrote a narrative review on this topic, and it was published in 2020. You can see the reference over here, so you can always look into that after the presentation. But I will give you a short overview of what is already known in this field. And we have about 8 papers that already have been published in this field. The first paper was published in 2007, was a paper by Deland, and the last paper was published by our own research group in this year. So what we know from these type of studies, some were randomized control trials, and some were more in a pilot experimental trial. Then when we look into the parameters or the laser devices that they were using, so the first 2 studies by Deland and Vive were focusing on LED devices, so where they were using a device at a wavelength of 590 nanometers with a very low fluence of only 0.15 joules per square centimeter. But other PBM parameters were not mentioned in these papers. Then we did a first study in 2016, which I will explain to you later, with the M6 MLS laser. And then there was also another study by Strutos. They also used a LED device. Now we did a new study in 2018. And then with also the same M6 MLS laser. And then Zhang did also a study with a LED device, but they also did not specify the PBM parameters. And that's really a problem that we see nowadays still in the field of PBM research, is that some researchers do not describe their parameters or their devices very well in the paper. So it's very hard to compare results between each other, because PBM parameters are very essential to the effect of the treatment. So what we can conclude from those research is that most used a laser or LED device with a fluence between 2 or 6 joules per square centimeter, and they all used a wavelength between 630 and 905 nanometers. Most studies were in breast cancer patients. Only the last 3 studies were also in head and neck cancer patients. Also, our last study from our research group was also with head and neck cancer patients. Why those type of patients? Because those type of patients suffer the most from these type of skin reactions. So that's why also the focus on these groups of patients was given in this field. When we were looking to the frequency of the PBM therapy, the first 2 studies by Delan and Fife, they apply PBM on a daily basis, sometimes before, sometimes after the radiotherapy session. Fife used it both after and before the radiotherapy session. We, in our studies, always use it 2 times a week due to practical reasons. We did it only 2 times a week, but it can be used, of course, daily, on a daily basis, like in the first studies. It would also be logical to use it every day because you're doing radiotherapy every day, you're damaging the tissue every day. So it's logical that you can also apply PBM daily to also overcome the damage that you're doing by applying radiotherapy. But due to practical issues, we only did it 2 times a week, and it already had good results, which I will show you a little bit later. You always saw that since our studies started off or published, most did it on a 2 times or 3 times a week during the radiotherapy session. So it seems sufficient to do it 2 or 3 times a week, but when it's possible, you can always do it 5 times a week or during every day of the radiotherapy. And we were looking into the results. So the first study, the study by Delan, did show a significant reduction in radiodermatitis, but especially a decrease in grade 2, grade 3 skin reactions. Then Fife tried to repeat those results, but they weren't able to show any significant results. And then we started up our studies, and we did show significant results, but I will go into that a little bit later. So in general, we can see that most of the studies really show a decrease in acute radiodermatitis, but more the severe acute radiodermatitis. So we cannot really prevent PBM grade 1 skin reaction, so the dull erythema and the dry desquamation. That's why we still need standard skincare next to PBM treatment. But we can use PBM to especially prevent the more severe type of skin reactions, so the grade 2, grade 3 skin reactions, so that are characterized by more moist desquamation and are the more, of course, more painful skin reactions that we see by our patients. So that is a little bit more about research, what is going on nowadays and in the world on PBM. So you can see that it's not really a lot, only 8 trials, because when you're looking into PBM and oral mucositis, there are much more. There are over 100 or 200 studies on PBM and oral mucositis. So it's a much broader studied field, and also PBM for oral mucositis is already into the guidelines of the MASC, of the ESMO, so the main research groups and organizations in the field of oncology. But for PBM and acute radiodermatitis, we're still at the beginning. So we are trying to make it happen, and also to have PBM in the supportive cancer care guidelines for acute radiodermatitis. But there is still a little bit, a long way to go to reach it, because the research is also, really limited. But now I would like to focus on what we did in this research field. And like I already told you, we did a first trial. There was a Golden Dermis trial in 2013, 2014. It was a study was performed at the Jesse Hospital in Hasselt, Belgium. And in this first trial, we wanted to investigate, can we use PBM in a treatment of acute radiodermatitis, and especially in breast cancer patients. So what we did, we set up a study with breast cancer patients who underwent post-lumpectomy and who underwent a standard radiotherapy regime of 25 fractions to the whole breast, followed by 8 fractions to the tumor area. We had 2 different types of groups. We had one group of patients who underwent the standard skincare. They were recruited in the first phase, and then in the second phase of the study, we recruited 38 patients who underwent the standard skincare in combination with PBMT, starting from a radiotherapy dose of 40 grays. So when the patients already developed a grade 1 skin reactions, they already presented some type of skin reactions. We treated patients 2 times a week, and they received in total 6 sessions. So here you can see a patient underneath the M6 MLS laser undergoing the PBM treatment at our institute. And when we were looking into the results, we can see that at a dose of 40 gray, most patients in both groups had a grade 1 skin reaction, which we also expected to see. While towards the end of the radiotherapy, we can see there is a clear increase in grade 2 skin reactions in the control group, around 30%, while only 1 patient in the PBM group developed a grade 2 skin reaction, which indicates that PBM was able to prevent the development of grade 2 skin reactions, so the moist desquamation, which we also expected to see. Now, based on that, we started up another trial, which was called the transdermis trial. And in this trial, we wanted to see, can we use PBM also to prevent the development of acute radiodermatitis in the same type of patients? So what did we do? We also evaluated PBM at a clinical level, but also at a biophysical level. We did a randomized placebo-controlled monocenter trial at the Yasta Hospital with the same type of patients. And we did randomize the patients to the control or a PBM group. Both patient groups received a standard skincare. The main difference is that the patients in the control group received a placebo treatment, starting from the first day of radiotherapy 2 times a week, while the PBM group received a true PBM treatment also for 2 times a week. In total, they got 14 sessions. Patients were always blindfolded, so they didn't know if the device was switched on or not during the sessions. So we used, of course, the M6 MLS laser at a fluence of 4 joules per square centimeter, and we treated the whole breast and the inframedullary fold and the axilla. And the duration of the treatment took around 10 to 15 minutes, depending on the size of the treatment area. We used the scanning head mainly for the breast, and we also used the manual device for the inframedullary fold or for the axilla when it was not reachable by the scanning head. So in the transdermis trial, we have 2 papers. One was published in Supportive Cancer Care and one in Lasers in Surgery and Medicine. So in total, we had 120 patients, 60 in each group, and there were no significant differences between the 2 groups regarding patient and treatment-related characteristics. So at a clinical level, we use also the RTOG rating like we did in our first trial, and the results are quite comparable when we are looking into our first trial. We still see that most of the patients develop a grade 1 skin reaction, both in our control and in our PBM group at the end of the radiotherapy. But what we really like to see is that around still 30 to 35% of the patients still develop a grade 2, grade 3 skin reaction in our control group, while in the PBM group, only 5% of the patients developed a grade 2 skin reaction and no grade 3 skin reaction, which we are really happy to see that we can use PBM to prevent those very severe types of skin reactions due to radiotherapy. And also when we evaluated the skin at a more biophysical level, we evaluated the pigmentation degree, the transepidermal water loss, and also the skin hydration. And we measured it on both breasts, both the control and the irradiated breasts, to make a comparison, of course, and we did it at the same time points. Now, when we looked at the erythema, we saw in general at the end of the radiotherapy that the mean change in erythema was significantly lower in the PBMT group in comparison with the control group. The same was true for the change in melanin, so also the discoloration of the skin was significantly lower in our PBM group in comparison with the control group. And also when we looked at a transepidermal water loss, a transepidermal water loss is correlated with the skin barrier function. So the lower the transepidermal water loss, the better the skin barrier function. So we saw in our control group that the transepidermal water loss increased, so it means that the skin barrier function diminished in this group, while in the PBM group, it improved. And on the other hand, we didn't really see any significant difference in hydration, which implies that PBM didn't really have an effect on the hydration level of the skin. And therefore, we still need to use, or the patients still need to use a hydrating cream alongside their PBM treatment during radiotherapy. So we can state that PBM can be used to decrease the severity of acute radiodermatitis, and it is demonstrated both on a subjective and a more objective level. And then finally, we also did a trial in head and neck cancer patients. It was a multicentric trial at 2 hospitals, Jesse Hospital and Zoll. And we used the same study setup as in a transdermis trial, but of course, another patient population. There were head and neck cancer patients undergoing radiotherapy with or without chemotherapy or surgery. And we also used the same type of study groups and the same setup, standard skincare in combination with placebo in the control group, and in the PBM group, standard skincare in combination with radiotherapy, with PBMT. They also were treated 2 times a week during the whole radiotherapy session. So in this case, we also use the M6 MLS laser in the biostimulation mode, also at a fluence of 4 joules per square centimeter. So we did not change anything to the PBM parameters. But for this type of patients, we did use a manual handheld device because it was much easier to reach the skin area. So it was not very practical to use in this case the scanning head. And we were looking into the results. We still see that most of the patients in our PBM group develop a grade 1 skin reaction. We see that the grade 2, the incidence of grade 2 skin reaction is a little bit higher than we saw in our breast cancer patient population, so around 30%, which we'd also expect because those patients undergoing radiotherapy in combination with chemotherapy, so that chemotherapy is also aggravating radiodermatitis, so it's a little bit higher, but we still see a significant difference with our control group because in our control group, around 80% of the patients still develop a grade 2, grade 3 skin reaction. So there is still a clear difference between the 2 groups in the grade 2, grade 3 skin reaction incidence. So PBM is still able to have a beneficial effect in these type of patients, like we already saw in our breast cancer patient group. So, and a little bit on the safety of PBM. Sometimes I get a question of oncologists or radiotherapists, is PBM safe to use? Because we all know that PBM can induce proliferation of cells. And we did a review on that topic, and I will go very quick over that, but we did a study, and we reviewed in vitro studies, in vivo studies, and the clinical trials that are available. This is published. This paper was published in Cancer Medicine in 2020. And based on the in vitro studies, there were 45 in that field. There were contrasting results. So some did show that PBM could stimulate the proliferation of cancer cells. Others did not show that effect. Based on that, we cannot really say one general conclusion. We really know that some studies really use a very high PBM dose, so it's not really clinically relevant, so these in vitro studies. And we also cannot make any consensus based on in vitro studies due to the missing interaction between the cells and the system in the target tissue that we have in vivo studies and in clinical studies with patients. Then based on in vivo studies that we looked into, we saw that different malignant cells may also react different to PBM parameters and also the doses. But we also saw that PBM can have an anti-tumor, that can stimulate anti-tumor immunity. And also in a very recent study, we saw that PBM does not safeguard tumor cells against the cytotoxic effect of radiotherapy. Now, and in my opinion, the results of the clinical trials are most relevant in this case. And up to now, there are no known side effects of PBM in oncologic patients. There are about 9 studies that studied this safety in oncological patients. And based on those trials, we can conclude that PBM does not influence tumor or treatment outcomes and the overall survival. Even some studies did show that PBM did improve the overall outcome of the patients in comparison with control patients who did not receive PBM. And that was especially in the field of oral mucositis. But we are also looking into safety, and based on that, we can state that there is in general no significant difference in overall survival or in disease outcome between our control and our PBM patients. So it's PBM seems safe in these type of patients. So in general conclusion, PBM can reduce our acute radiodermatitis, but especially the more severe types of acute radiodermatitis, so grade 2, grade 3 skin reactions. It can thereby improve patients' quality of life and also improve the supportive cancer care. And it also seems safe to use in this oncological patient population. So I want to thank you for to listening to my presentation. I went a little bit over time, but if there are still some questions, I'm very eager to answer them. Or if you have any other question, you can always mail me to my email address. You can find it here in this slide. Or you can also go to our website of Lowlight to see more information about our ongoing studies at the Institute. So thank you, and I hope to see you at another conference or a presentation. Thank you.
Wonderful. Okay, thank you very much. That's really great. We've got a lot of comments coming through from people saying thank you for that comprehensive presentation and also your summary of your research. And I think covering particularly that last area of safety is really important because we get a lot of questions, especially related to oncology, as how safe is laser to use? That's a very, very big one. Now, we've got a few minutes here. We've got a couple of questions that I would just like to run through. Let's just start here, I think. Okay, so Michael, thank you for those questions. Looks like they got answered as we went. Can you see these questions, Jolyon? Yes?
Yes.
Yeah, okay. So I guess let's look at one question here. Was there a total dosage baseline required to get the effect, i.e. overall joules administered, not just the joules per centimeter squared, or was it just 4 joules per centimeter squared over whatever treatment area?
Yeah, it was just 4 joules per square meter over the whole treatment area. So the M6 MLS laser, when you set in the treatment area size and fluence, it will automatically calculate the treatment time. So it's a whole area that will get the 4 joules per square centimeter during one treatment session.
Okay, and research is very consistent on that dose, isn't it, for treatment?
Yes, so now the guidelines that we are writing now, we are stating that we can use effluents between 2 and 6 joules per square centimeter in the case of acute radiodermatitis. The guidelines that we are setting up now will probably say that we will suggest to use at least 3 joules per square centimeter in a more preventive manner. And once skin reactions have developed, we would suggest to use 6 joules per square centimeter. So, but based on our evidence, 4 joules was enough to see any difference or to see an effect. But probably a little bit higher fluents can also have a better effect. But that's always a difficulty with when you're using PBM. You not really know what is the best dose to use. Therefore, you really have to do a comparative study between the different doses to make conclusion on the scientific.
And I suppose one of the advantages of the MLS system is how easy it is to see that dosage. So that kind of makes that easier. One from Fiona here says, thank you for your presentation. Do you have guidance on how to avoid overdose when applying PBM?
Not exactly. So I don't know what you mean by overdosing.
Can you give a patient too much or a too high a dose?
I don't think so. When you keep it to between the guidelines between the 2 and the 6 joule per square centimeter, I don't think you can overdose. Sometimes we saw in an in vitro study or an in vivo studies that they use effluents with around 100 or 200 joules per square centimeter. I think that it's not clinically relevant to use that types of doses in humans. So when we keep it between those doses, I don't think we can overdose the patients by applying it.
There's a question here. Were you able to follow up the breast patients to see if PBM also reduces complications of lymphedema after radiotherapy?
Now, for our studies, we didn't look into that. So the transdermis trial or the dermis head trial, we only look into overall survival and disease outcome, or so we look more into the safety issue when we are following up those patients. But we are now doing a specific study on lymphedema. So it is the breast cancer-related lymphedema for the arm, the upper limbs. And in this case, we are following up the patients up to 5 years post radiotherapy to see if there is any effect of PBM on a long term. But for the radiodermatitis, we don't follow up patients for the lymphedema part.
And we'll be hearing more about lymphedema in our next webinar with you, which is going to be great. Now, Kate, hi Kate. Is the setting for PBMT set on biostimulation treatment? Is that the setting that you're using for your treatments?
Yeah, we use a biostimulation mode,
Okay, all right. And she's also got a comment, I've got a head and neck cancer patient who's halfway through treatment, skin's very red and inflamed. I'm assuming it's okay for me to perform PBMT on this patient? Yeah,
of course.
Okay, so any tips or advice on that treatment?
I would suggest to use it at least 2 times a week if it's possible. We are now doing a study that we are applying it each day. So because there is advice from the Wolf and from the mask that it will be more beneficial to use it daily during each fraction of radiotherapy, if it is practically possible. But when we are now applying it into in the standard practice, we are only applying it 2 to 3 times a day, 3 times a week, because it is not practically possible to do it on a daily basis. But for in a study, we are now doing it 5 times a week. It also seems logical to do 5 times a week because you're damaging the tissue each day, and then it would be logical to use PBM to recover that damage. But of course, always use standard skincare next to PBM. So we always advise patients to use an hydrating cream alongside PBM, because we saw in our research that we cannot really prevent the dry desquamation and the erythema. It will be less in patients undergoing PBM, but it will not totally resolve alone with PBM.
And so I think it's very interesting to see your research point out what PBM does not affect, so that you can keep the patient hydrated and come up with some things. There's a question here: has your research translated into greater use in the clinical setting?
Yes, so we are using it now for breast cancer patients, because there are a lot of breast cancer patients. Today, it's not really possible to do each patient with PBM. So we set up some guidelines. So we, based on our research, we saw that patients with very large breasts, so a high BMI, and patients who underwent chemotherapy have a higher risk in the development of a more severe type of acute radiodermatitis. So now we do it for these type of patients. So those high risk patients, we do it in a preventive manner. So they will get PBM from the first day of radiotherapy. And other patients who still develop a grade 2 or higher skin reaction during radiotherapy, we will apply PBM in a more therapeutic manner. Because for patients who only develop a grade 1 skin reaction, it doesn't really seem beneficial to apply PBM next to standard skincare, because we cannot really prevent a grade 1 skin reaction by applying PBM. So it will be not very time beneficial when we apply it to everyone. So therefore, we decided to do it only to high-risk patients and patients who develop a grade 2 skin reaction. Maybe when they're in the future will be a device that the patients can use at home, then it would be ideal that then they can do it, of course, every day. But in the hospital setting, for us, it is not possible to do it for all patients, and especially not on a daily basis, because we now have a special nurse, wound care nurse, that is taking care of it. So it's separate from the radiotherapy session.
Okay, we have quite a few more questions, but I'll just do a couple more and then we'll let you go and get on with your day. But is PBM beneficial for seromas?
I'm not sure for that.
Okay.
I'm not into that.
Okay, and another question is, a fine plastic film is often used to reduce radiodermatitis. Is the dosage the same, and is it safe to use PBM over the film?
We also did a study on that film at our institute for breast cancer patients, but we did not compare it with PBM, or we did not use PBM in these type of patients. But we decided not to go further with the film, because it was very difficult to apply it on the skin, and it did not. So the patient, it went off, and then the nurse had more time to put it on the next time. So we did not use it. We do not use it anymore at our institute. But we did study the effect of film and the dose of radiotherapy on the film, and radiotherapy dose wasn't altered by the use of the film. So, but I'm not sure if PBM can be used on top of the film. So that I'm not sure. Okay. We are not really a fan of the film anymore. We just keep it to the creams and the Mepilex. We call this as a silicone dressing, but the patients take the silicone dressing off during the PBM session. Okay. And then they apply it afterwards again on the wound.
Thank you. I think we'll wrap this up now. I know there's a lot more questions. We will follow up with this. I just put a link in the chat for everyone. If you want to click on this link, you can find more information and get in touch with us. We will follow up and make a recording of the presentation tonight available to everybody. And we will also, we're putting together a resource document with all of your papers, so that we'll make that also available to people. So if you are interested and want some more information, certainly come on board to our website and let us know what it is that you'd like to find out in more detail. And we look forward to seeing you in September, when you're going to come back and talk to us again.
Yeah, great. I'm looking forward to it.
Okay, thank you very much. And we look forward to you next time. Again, thank you for your time.
Thank you. Bye.
Okay,
Have a good
bye.
night.
Okay, you too. Have a
Bye.
good day. Bye-bye.